Over the last 2 years, the world has been shaken by the stories of Alfie Evans and Charlie Gard, two infant patients treated by England's National Health Service. The two unrelated cases had appalling similarities. Both Alfie and Charlie were suffering from terminal illnesses, and both Alfie and Charlie were denied potentially life-saving treatment outside of the United Kingdom. People around the world were haunted by the fear that they wouldn't be able to control their medical care, the fear of being held against their will. And these two cases are just a microcosm of what has become a string of NHS scandals. And despite such scandals, United States politicians, such as Bernie Sanders and Elizabeth Warren, are calling for healthcare reform, potentially modeled after Britain's NHS. Just after this, I talk with Rupert Darwall about what this could mean for the United States in a direct, uncensored interview. Stay tuned and keep listening. I'm Luke Scorzel, and you're listening to Bills. So before we get into the interview, I'd first like to say a quick thank you to all of the patrons to the Bills Luke Scorzel podcast. So we have Zach, who gave a tremendous $30 donation, greatly appreciated. Zach actually got to participate in the last interview with some questions for our guest. So the one with Brian Nichols, he got to send in some questions, and I asked Brian the questions, and they were actually pretty interesting. So if you'd like to become a patron, you can go over right now. Thank you also to Tiana, Mike, and Julie for their $15 donations. Very greatly appreciated. And thank you to Scott and Michelle for their brand new $10 a month donation. All the support is welcome and loved. So thank you all so much. And without further ado, let's get into the interview. Our guest today is a graduate of Cambridge University, a co-founder of one of London's leading think tanks, a multi-published author, and a contributor to the Financial Times and the Wall Street Journal. Welcome to the show, Rupert.
Glad to be joining you, Luke.
Before we get into your article for the Wall Street Journal on reform in the British National Health Service system, can you tell us a little bit about your background and what you do for a living?
Right. As you mentioned, I went to university in Cambridge, and after that I worked in the Conservative Research Department, which is a part of the Conservative Party. That was in the mid-'80s. I then worked in the city as a stock analyst, and then in corporate finance, and then for a short spell I was a special advisor at the Treasury in the 90s. And since then I've kind of been working with think tanks, doing freelance consultancy work, and doing a fair bit of writing.
You also contribute a lot to the Wall Street Journal, and that's what brings you on the show today is actually your piece entitled Reform the NHS Before It Kills Again. Shocking title. But can you explain what motivated you to actually write that piece and what it is about?
Yeah, it was based on a report, an independent report into some events at a small hospital on the south coast of England, Gosport War Memorial Hospital, which is quite near Portsmouth. It's a kind of a naval area. And I think the reason I wrote it was because 5 years ago, I wrote an article for the Wall Street Journal headlined, Luke, Why the NHS Keeps Failing Britain. And that article was on another independent report, which was into the failings at another hospital, the Mid-Staffs Hospital in England's West Midlands. And in fact, what is shocking about the Gosport Hospital is what happened there was even worse, is even more horrifying. Essentially, the clinicians there were running a euthanasia ward. I mean, putting it very bluntly, an involuntary euthanasia ward, I should say. So patients were going there who were admitted for rehabilitation, and their relatives were told, oh, the best we can do is to be a sort of kind, gentle good night kind of thing. And they were basically killing off these, or as the report says, shortening the lives of these patients. And I found the whole thing so shocking. I read the report, and it's an extremely well-written report, extremely thorough, quite long, but well worth reading. And in there, really everything you need to know is in that report. There's nothing hidden. But it is an utterly shocking report.
And we're going to delve into the situations that you're talking about in those circumstances. But first, as we're talking about this government-provided healthcare system in the United Kingdom, I'd like to ask a little bit of the basics. So how exactly does government-provided healthcare in the United Kingdom work?
I think one should make a distinction conceptually between government as the funder of healthcare and government as the provider of healthcare. And what we have in the UK is the government is both the provider and the funder of tax, the provider and the funder of healthcare. So it owns the hospitals. All the staff in the hospitals are public employees of the NHS. The primary care physicians have contracts. They're self-employed. They have contracts with the NHS. But essentially, you're talking about a system where the NHS represents about 95% of the provision of healthcare. So it's a fully, deeply nationalised system of healthcare.
And of course, a system that the United States, as some politicians are calling to replicate. As far as access to care goes, who exactly has access to that system? And do citizens actually get a choice in which hospitals they are going to and which doctors they're seeing?
Right. The kind of big selling point, the big bull point of the NHS is that it's open to everyone. That everyone gets it. It doesn't matter who you are. You get access to treatment. Now, you raise the question of choice. And choice is, first of all, you have to say that it's slightly complicated because you've got, in the United Kingdom, you've got England, you've got Scotland, Wales, and Northern Ireland. And when people talk about that, they tend to concentrate on England because what happens in England is actually slightly better, if you can believe it, than what happens in the rest of the United Kingdom. What happens there is much more even more socialised than in England. But in England, thanks to the principally to reforms in the 1990s and then by the Blair government in the first decade of this century, there was an attempt to open it up a bit and to introduce a bit of what Tony Blair called choice and competition. So the idea is you might get a choice of 2 hospitals rather than 1 hospital, right? But in London you get a bit of a choice, but elsewhere the choice is very limited. So the poor people of Mid Staffs, for example, didn't have a choice. They went to Mid Staffs and they knew it was a terrible hospital. A lot of local people were upset about it. They felt they had no choice but to go there and have really terrible, terrible treatment. And it's that lack of choice, lack of competition that is the big problem when you have a monopoly provider. I mean, when you have a monopoly provider, you don't have choice. So it means that standards can go. You're grateful for what you can get. But I think there's a similar problem with the VA in the United States, where there have been stories of terrible veterans receiving really poor care, and this is a problem when the government provides, not just funds the healthcare like with Medicare, but actually is the provider of healthcare, and it runs the hospitals. You've got a big problem there. There's an immediate conflict of interest between the government saying you're going to get really quality healthcare, and if you don't, we as a regulator are going to call out the abuses. But when the government is running the healthcare, it tends to say, oh, well, it's actually, you're very lucky to be getting this,
Yeah,
tug your full lot.
And that's what we hear all the time is that these other countries are so much better than the United States because they have this total universalized healthcare that is provided by the government. So another interesting question that I have for you that maybe isn't brought up very much is whether members of government are actually on the same healthcare system as the citizens.
Yeah, government, ministers and MPs, it's like this great virtue signal. I got treated on the NHS and the NHS is wonderful. They all get treated. But if you're a senior politician, if you're someone important, obviously, you get treated better. You're not going to wait in line. You're not going to have to be. You're not going to be put in on a waiting list and wait a couple of months because you're an important person. I mean, in that respect, it's rather like what happened in in the Soviet Union. Kind of everyone's equal, but of course the people at the top are more equal.
Delving into actually the article itself, well, actually, before we do that, I'd like to ask, what are some of the positive aspects of the NHS before we go total negative for the rest of the interview, but are there any that you can immediately think of?
Yeah, I wouldn't say this is a positive, but what used to be seen as a positive is that when the government runs healthcare, it determines how much healthcare, the overall spending on healthcare in the economy. So if one of the things that the US is criticized for is it spends nearly double as a percent of GDP what any other country spends on healthcare, yet so we're told the health outcomes are about the same. So if you like, the virtue, and I don't believe this is, I don't go along with this, but just in mechanical terms, if you like, if you have a single payer system with the government funding and providing the healthcare, it can determine the total amount of resources the nation spends on healthcare. It can therefore ration healthcare. Now, I think that's a really quite bad thing. I don't think the government should decide how much money people spend in aggregate on healthcare. That should be a decision for society as a whole, acting through markets and so forth. But if you basically think too much is being spent on healthcare, and that was one of the arguments put forward by Obamacare, that the US are proponents of Obamacare, that too much was being spent on healthcare. This is a way of rationing it, but then you get all the problems you get with rationing.
Definitely. And so getting into your article, there's one really shocking line that stands out from the beginning, and it's NHS managers covered up the unlawful killing of up to 650 patients at the Gosport War Memorial Hospital that we'd talked about. A few questions. When did this happen? And then what were the circumstances that actually led to these 650 deaths at Gosport Hospital?
It started off in the early 1990s and it lasted about 10 years, and it peaked in 1998. And what happened in about 91, 92, a couple of nurses were very concerned about the prescribing practices in that ward, in that hospital. And they raised it with their managers, and there were some meetings, 2 or 3 meetings were held. And to their credit, the nurses' trade unions, the Royal College of Nursing, they got involved and stuck up for the nurses. But what then happened was the clinicians and the hospital managers basically said, you nurses don't know what you're going on about. You don't really have a right to question a clinician who is higher up in the hierarchy than you. And if you do have a problem, you should raise it directly with her, which is tantamount to saying, mind your own business. And that's where the issue lay. That was the cover-up. And then what happened is, as I write in the article, I talk about Gladys Richards, which happened in 1998. And her 2 daughters complained to the police about her treatment, and then the whole thing very, very gradually got more attention within the system, and we can go into some of the phases of that, which is very interesting. But what you saw is the managers and the clinicians suppressing the complaints raised by the nurses, and of course after that, if you were a nurse, you weren't going to complain again. It had been dealt with. You did what the clinicians said.
So then, if I'm getting you right, it was rather than the negligence of the actual nurses, it was more so these higher-up bureaucrats that were telling the nurses to stop complaining and just
Correct.
To keep funneling people out of the system. Because there's also reports that come out all the time about how Britain is cutting back on beds in the hospitals because they're short on money and that type of thing. So it seems to be more than treating the patients, it's get them out as quickly as possible.
Well, I think what happened, I should say, going back to what happened to the nurses, if you read the report, they talk about how the nurses were ostracized, that if you're a whistleblower, which they were, it would be very difficult to carry on working in that hospital. And so it's like the complicity of the clinicians, the other staff, the managers. Basically, there was a culture of not reporting and not elevating the things that that these nurses were concerned about. And that's just suppressed their concerns. And from that moment on, it was almost like, and that's when the momentum for the over-prescribing of opioids, which they knew what they were doing, the clinicians knew what they were doing, which was resulting in the foreshortening of the lives of people, and in some cases, patients who were expected to get better and leave the hospital. They were being killed. They were being killed off at this hospital.
And that is the case of what happened to Gladys Richards, was that I believe she was overprescribed opioids by Dr. Jane Barton. So that just seems to be commonplace within the National Health Service hospitals and trusts.
I wouldn't presume to know that. But what is the case is that if things like that happen, we don't get to know about them, and the institution tends to suppress these things happening, so suppress concern. So it's because of the basically terribly conflicted. You've got the NHS, which is this kind of monopoly provider of healthcare. It's therefore virtually a monopoly employer. So it has tremendous power over people, and you're just not going to step out of line. Again, this is a tremendous cultural problem when you have a monopoly, such a hugely entrenched monopoly, where the bureaucracy, and to run a single payer system it involves a huge amount of bureaucracy, and the interest of the bureaucracy is keeping the lid on things. It's not exposing things.
Similar occurrences to Gosport War Memorial Hospital have occurred at other NHS hospitals. You also wrote that in 2015, the Francis report in the Mid-Staffs Hospital, which we talked about a little bit, that they found appalling and unnecessary suffering of hundreds of people. They warned of highly concerning reports of similar experiences elsewhere. So very harsh language used by Francis. And what was care like at Mid-Staffs Hospital to warrant this language?
Yeah, they talked about, the report talked about a lack of care, compassion, and humanity. They said that fundamental rights to dignity were not respected, that elderly and vulnerable patients had been left unwashed, unfed, without fluids, and there were incidents of callous treatment by ward staff. And as you say, they said there is strong evidence that Mid-Staffs was not an isolated incident. So that's, if you like, callousness and not elderly people in bed, bedbound, who are not getting fluids. I mean, it's just extraordinary. And this is meant to be about caring for people. And but I think what was happening at Gosport was even worse, in that you had clinicians taking the decision to end the lives. This isn't just negligence. This goes a step beyond that, to actively ending the lives of patients by prescribing them fatal doses of opioids, and they knew what they were doing. There's no way. They knew what they were doing. The line in the, as you may recall in the article, at one point Jane Barton says, and after that there will be a chest infection. It's not that there'll be a chest infection. What happens is when you have an opioid toxicity, it collapses the lungs. So on the death certificates, they'd write down bronchopneumonia. Mm-hmm. And that's how the investigators, one of the things the investigators found was the spike in death certificates with bronchopneumonia as the underlying cause of death tracked the increase in deaths and the opioid overprescribing on that ward.
We kind of attributed the blame to the bureaucrats earlier, but it seems to be that there comes a point of responsibility as a physician and as a caretaker to have the patient's best interest in mind. So actually prescribing opioids, and I don't know if in hopes would be the right language to use, that the patient would eventually die. I mean, what is the motivation behind that, do you think? Why? I mean, that's rather shocking.
I think it's incredibly shocking, and it's I think it's because of I'm choosing my words carefully here. All I've done is read the report, but what strikes me is on that ward there was a culture of death. It was the opposite of the respect for life. There was a culture of death. This wasn't, it should be very, very clear. This was not palliative end-of-life care. This was not a humane way of people who were in pain and letting their last few days and hours be lived as pain-free as possible. That is not what was going on. This was clinicians deciding that this such and such a patient was at the end of their lives, and their lives were going to be ended. And so there's one case, an absolutely shocking case, where a troublesome male patient, a nurse said if he doesn't watch out, he's going to be put on syringe drive. And lo and behold, he was, and 3 or 4 days later, he was dead. And here was a case of someone who was seen as a bit of a troublesome patient on the ward. He was perhaps demanding, might be a bit suffering from dementia or whatever. And a decision was taken that the troublesomeness would be dealt with by giving him a lethal dose of opioids. How do you describe that culture? It's a culture of death. It's something that is the absolute antithesis of what medical care should be about.
Yeah, I mean, that's just shocking to hear because, well, you talked earlier that the patients were actually being admitted based on rehabilitation, and that's what they needed, and then you make clear again that that's not an end-of-life ward. And I mean, that truly is scary because you go to a hospital and you expect to be cared for and to be let out alive and hopefully better than when you went in. But if people are being essentially murdered in these hospitals, I mean, it's just hard to fully take in.
Yeah, absolutely, Luke. I think that's what it is very hard to understand. It is so opposite to what we see hospitals and clinicians should be about that it's difficult to get one's head around it. And the report does not speculate on the motives or the philosophy, if you like, of those clinicians. But it is unbelievably shocking. And what happened is in there, black and white. This is not what they describe there is not speculation. These are things that happened. And we're talking about, as you mentioned earlier, we're talking about 650 lives, up to 650 lives were foreshortened, as the report says. And in some cases, not in all, but in some cases, those were individuals who'd have been expected to have left that hospital and gone back home.
Mm-hmm. Were some of these patients likely to end up down the road dying of natural causes then, and the physicians just exacerbated this?
I think it's difficult to say. The report chooses its words very carefully, and the words they use are foreshortened. Their lives were foreshortened. And this wasn't, as I said earlier, this isn't palliative care being given to end-of-life cases of people suffering from cancer or terminal diseases. So Gladys Richards, who we mentioned earlier, she had a dislocated hip, and her relatives expected her she'd come in from another hospital where they put her hip back, and she was there for rehabilitation and with the expectation that she'd be discharged. So this is something beyond. It's very difficult to comprehend what happened, and that's why I think the sort of terms, the culture of death, is kind of helpful in a way to get an appreciation, if not an understanding, of what went on at that hospital and that ward.
Mm-hmm. So then, if Gladys is just in there for rehabilitation on her hip, then why were opioids used in the first place? And maybe the report doesn't necessarily mention this, but I mean, that just seems like a big stretch from going in to have rehabilitation, and maybe she had pain, and so that was part of it, but to the point that they were able to overdose her.
Yeah. Luke, the report makes clear that she was not in pain. She was not in pain. there was no objective, there was no clinical need for her to receive opioids, let alone in the quantities that killed her.
Well, that is shocking. And I mean, it's hard to even know what to say when something like that happens.
And then you see when this thing, it started because there were 3 police investigations, and when it started sort of bubbling up within the NHS that these things have been happening, a dozen clinicians wrote to the chief medical officer of the NHS in England saying these prescribing practices were, Dr. Jane Barton wasn't alone. We did the same thing. So that shows how ingrained, if you like, these practices and this culture was within that hospital, within that locality. They didn't see anything wrong in what she was doing because they were doing it too. And not only that, they were telling the chief medical officer of England that that's what they were doing. And they thought that was perfectly okay.
Seems as though they'd forgotten their roles as caretakers and people who are supposed to be treating their patients, not killing them. On from that, into those investigations, you say that the investigation into Gladys' death uncovered evidence of criminality, but that it was difficult to call to account those responsible. So what exactly got in the way of the investigation? You've told us about the other nurses at the hospital who sent in letters saying that this was a commonplace practice, but was there anything else?
Yeah, sorry. What kicked off that in fact, the report begins with the meeting that the nurses had, raising their concerns, and that trail went dead because it was essentially suppressed. What went on it came out as a result of Gladys Richards' 2 daughters. After their mother's death, they took the matter to the local police, and the police then started an investigation, but it was done at quite a low level, and the detective leading the investigation was clearly not up to the job, very deferential to the doctors, the clinicians, and the police thought the issue was the family hadn't been told, the complaint was we haven't been told what was going to happen to our mother. And they ascertained from talking to the doctor, they were told very clearly what was going to happen. So there isn't an issue here. Of course, the issue was not whether they were told what was going to happen to their mother, but the fact that the doctor was over-prescribing opioids and therefore killed their mother. And the police, so that investigation kind of died because the police were basically, Luke, too stupid to understand the underlying issue, which we discussed. Then there was a second investigation, and the police got in a professor from a London hospital, Chelsea and Westminster Hospital, Professor Brian Livesey, and he reviewed the evidence, and he came to the conclusion, and you've actually mentioned it, that he would support allegations of manslaughter and actual bodily harm, and that's very, very serious. That is criminality. Those are it's a very, very serious allegation. But he saw the evidence and was very adamant that the evidence supported those allegations. And then came a shocking episode, because this was in the run-up to the 2001 general election, and that was at the end of Tony Blair's first term as Prime Minister. And during that time, Labour had put up national insurance, its like social security tax, to fund an extra payments to the NHS. So the NHS was a bit of a political issue. And the police, in their discussions with prosecutors, said, well, we've got to be aware that some people are concerned about the impact this might have on the forthcoming general election. And then at a meeting with prosecutors closer to polling day, a lawyer retained by the Crown Prosecution Service basically sabotaged the emerging prosecution case. He said that the views of Dr. Jane Barton should be taken seriously. They shouldn't just be overruled by this professor. That there wasn't evidence that she hadn't died of bronchopneumonia. How do you prove a negative when you can't? I mean, he basically the result of that meeting was that the move towards prosecuting stopped at that point. Now, there's another thing that another aspect of this, it's when the police are having an investigation, the way the NHS responded and the bureaucrats responded was, oh, we can't do any more investigations of our own. So the police who were bungling these investigations, the effect of their investigations was to stop the rest, other investigations, if you like, civil procedures within the NHS. It stopped them in the track, to the extent to which that 2 NHS managers who'd been suspended because they should have acted when they didn't, they were pretty negligent in carrying out their duties, were reinstated because of the police investigation. They said, because the police investigation is going so long, we can't have these suspended. They've got to come back and back into their jobs. Even so, patient safety took another hit from that. It's just it's kind of something that you read in Kafka or something, or Gogol. Do you know what I mean? When you read this stuff, it's unbelievable what happened.
Yeah, I mean, it's unbelievable that this is happening in what is one of the most advanced countries in the world, and so this, what you're saying basically seems to hit at what we said earlier, and what you said was the problem with government-run healthcare and provided healthcare and funded, and even what you say in your article is that government essentially here is investigating itself, and the part that it was investigating was relevant in an election. And so they stopped investigating it as hard as they could. So, I mean, it's so convoluted and confusing. And well, I mean, not necessarily confusing.
No, it's not confusing.
Yeah.
You put your finger on it. You've absolutely put your finger on it. When the government is a provider and a funder and a regulator of healthcare, when it combines all those functions, it has a huge conflict of interest. And the result is patient welfare suffers.
Mm-hmm. And we're seeing it firsthand with this report.
Yeah.
So you mentioned some of Dr. Barton's defenses, and the Daily Mail actually had a report saying that she had written letters to the hospital authorities saying that they were sending her too many patients and that she couldn't cope with this number of patients. It seems as though she was putting out a cry for help, and obviously we've kind of attributed a label of negligence at best and maliciousness at worst to her, but what can we make of this report? Was it simply that she was receiving so many patients that she couldn't attribute proper care?
Yeah, it wasn't proper care. She was killing the patients off. And if that had been her concern, why was she so hostile to those nurses who raised the issue in the early 1990s? When things go wrong in the NHS, the cry is not enough resources. That's always the cry, not enough resources. But on the other hand, you could say that illustrates the problem with the NHS is that when they don't have enough resources, they kill people off. That is an argument against the NHS, isn't it?
Yeah, an argument you'd think you'd see in a dystopian novel about the distant future. So it seems that we are in 1984 plus another 20 years. Cases like this are really, as we've discussed, are occurring across the United Kingdom. P9 Acute Hospitals Trust saw the number of unexpected deaths soar more than 400% in just a year, from 86 deaths in 2015 to 435 deaths in 2016. So reports like this of misdiagnosis and incompetence seem to be rampant. Is this a systemic problem stemming from the NHS, or again, are these just really singular cases with no connection?
Yeah, very much the former, Luke. It is because of this. It's because it comes back to this combined role of being a funder and provider and regulator of healthcare. And that, as I wrote in the piece, there's something else going on. That in Britain, they say, oh, it's terribly evil. Profit in healthcare is really terrible, leads to terrible things. But a for-profit hospital does not have a financial interest in killing off its patients. In fact, the incentives are the opposite. The incentives are for over-treatment, of over-prescribing, of keeping patients alive for as long as possible. As a hospital, you get paid for the more care you give if it's for profit. Whereas in the NHS, every patient is a cost. That's a fundamental difference. That is, let's make the case for profit in healthcare. It's the absolute opposite to what happens in the NHS. And you mentioned all the things that have been these reports have come out. The Pennine one, Mid-Staffs, Morecambe Bay was another one where 19 mothers and babies were killed because of gross medical incompetence. All these are in English hospitals. This is where problems have been found. What's interesting is that we don't hear hospitals in Scotland or Wales where the NHS is, if you like, even more retarded than in England. And I'd have a pretty good guess that the things that have been happening in England have probably been happening in Scotland and Wales too. And the difference is they haven't been, that they're not being looked at.
So why exactly do you say that the other countries actually in the United Kingdom are actually worse off in terms of healthcare?
Because the sort of Blair-type reforms of competition, choice and competition, were rejected by in Scotland and Wales by the local politicians. So they take a much more antiquated view of the provision of public services, so that if you like, it's much more socialist, even more socialist than the NHS in England. But there's been long-standing sort of kind of newspaper reports of when people in Wales sort of think they might go to hospital, they cross the border and go to England, try and get into an English hospital rather than a Welsh hospital. So the only point I'm making is if things look bad in England, they're almost certainly worse in Wales and Scotland. Almost certainly.
And so your article is aptly titled, Reform the NHS Before It Kills Again. So I'd like to talk about some of the options for reform. We've just discussed, I think that those last few lines were pretty amazing, that the patients in the NHS are a cost on the healthcare system rather than a benefit, as they are in for-profit hospitals, as they get paid for treating the patients, which they should, because that is their goal, not to just get people out of the hospital so they don't have to pay for them. But on to reform, Prime Minister Theresa May promised an increase in NHS spending of almost 20% over the next 5 years. What do you see as a viable option for reform? And then is such a boost in spending going to be a step in the positive direction?
I thought her speech, which she made 2 days before this independent report into Gosport War Memorial Hospital came out, her speech was absolutely terrible. It was full of kind of the NHS is the envy of the world. The only thing wrong with it is it doesn't have enough money, and it doesn't have enough money sort of going forward. It doesn't have a commitment to strong spending increases. There was not a word, there wasn't even the slightest shadow that there might be problems, such as evidenced in the report that came out 2 days earlier. And the government knew, they didn't know the contents of the report, but they knew very well that there was a big problem at Gosport, because a previous report had estimated the number of excess deaths from that hospital. So they knew, the government knew fully well there was a big problem there. But even worse than that, Luke, was in that speech she said we're going to keep the NHS in public hands now and forever. The speech was on the 70th anniversary of the founding of the NHS in 1948. And she said, it's not just for the next 70 years, but forever to keep it in public hands. And that is the problem, is that the NHS being in public hands is what gives rise to these problems. And that's why her speech was so terrible. It's absolutely the wrong way to improve healthcare in Britain, is just giving an unreformed NHS a huge amount more money. By contrast, Tony Blair in 2003-4 was saying we've got to open the system up. It doesn't matter whether a hospital is publicly owned, if it's run by a charity or indeed a for-profit provider. What matters to patients is the quality of healthcare. And so what we've had in the last 15 years is a terrible regression from a hopeful way forward to breaking open the NHS monopoly, to Theresa May saying, I believe in the NHS monopoly, and just airbrushing out the problems that monopoly gives rise to in terms of really terrible patient care. I mean, there are surveys that show that the NHS scores very, very poorly on outcomes. And we're meant to be okay about whether it's survival rates from cancer or stroke, or the NHS scores poorly against internationally. The prime reason for that is that we have this monolithic monopoly provider of healthcare called the NHS.
In the United States, we have an abundance of research hospitals, most of which are tied with universities. So I'm in California, and we have the University of California, San Diego, the University of California, Los Angeles, Stanford University, the USC Keck School of Medicine, and just a tremendous amount of research hospitals that are all independently and also collaboratively working towards cures for some of these diseases. So does the United Kingdom have any types of research going on in the National Health Services or independent hospitals? Where's any progress happening?
There are some independent hospitals, but they're quite small. It's almost like the privately run bit is like a cottage industry. It doesn't have remotely the scale of that you get in the US, or indeed in many continental countries where healthcare, for example, a lot of French hospitals are run by charities. In Germany, you have a pluralist system of healthcare, whereas in Britain, it's essentially state-run and state-provided. We do have some good hospitals that are linked to universities, good research hospitals, and in London especially, there's quite a good there's quite provision of quality healthcare. But what you've got is this great sort of block of, the hospitals, if you like, across the rest of the country. The bog standard, if you like, general hospital is not a pretty experience. And to give you an example, Theresa May's constituency, where she's MP from, is Maidenhead, and the local hospital there, Wexham Park Hospital. It was a few years ago. It was so bad, it was put under special measures. So the thing is, with an independent hospital, it's got to maintain, if it's competing for patients, it's got to maintain certain standards, because it will go out of business. You don't have special measures. You don't need a hospital that is so badly run. It doesn't go into special measures. It goes bankrupt and someone takes it over. That's the difference.
It seems as though none of that's ever going to happen there. And this brings us to essentially the relevance of this conversation for a lot of our United States listeners. So in the U.S., politicians are looking at Britain's healthcare system as the ideal model for what universal healthcare in the United States would actually look like. So Bernie Sanders made calls for this during his campaign. We've heard it from Elizabeth Warren and many others, mostly on the left side of the aisle. But how do you think a system like the NHS would play out in the United States, where the population is so much larger and the country just physically is so much bigger?
Look, the short answer is if someone tried to create the NHS in the United States, there would be a revolution. I tell you, there would be a revolution. Americans would not put up with it. It's just so it's so culturally. It could not fly. It would whoever put that in, they wouldn't last. And going back to the NHS, you've got to remember it's a product of history. That it was in 1948, 3 years after the end of the Second World War, a war in which there had been 5 years of rationing, of quite a lot of hardship, food rationing, bread rationing, so forth. Then you had a very socialist Labour government that did a lot of nationalisation. They kept rationing on. And so this was a period in British history where people were used to a very high degree of socialisation. I don't believe if we hadn't had the NHS, that British people would say we want to have it now, and even more so Americans. I mean, it's so middle of the 20th century, in an era where people have access to so much information of self-empowerment and so forth. It is a system that simply is completely out of phase with the times.
I mean, I agree with you, and I think a lot of people do, but I mean, Bernie Sanders was a very strong contender against Hillary Clinton for the Democratic nomination in 2016 and had a lot of support for what he calls universal health care. And his system, he said, would cover 323 million Americans, which is most of the United States population. And I mean, we kind of addressed quantity over taking prevalence over quality in the NHS, but I mean, that is the epitome of having too many patients to care for in a lot of these hospitals, and it seems to be something that is gaining support in the United States.
Well, the thing is that the NHS is unmanageable. It's got about 1 million employees or something. You cannot manage. People go on about the Pentagon, don't they? And about how hard the Pentagon's like this kind of nightmare of it is very difficult to manage. No one knows kind of the bureaucracy and so forth. That is the case with the British NHS. It's impossible to manage it. There are things that get so big that only markets. You can't do that in defence and so forth. But in healthcare, you want a market, and you've got a market in the US. There are problems with it. There are problems in that you guys know better than I do, but the way the insurance market works, or it's been order. But the NHS highly socialised state-run model is essentially unworkable. And in the article, I quote a line from a government report from 2015 saying, the NHS is drowning in bureaucracy. This is what a government report said. The NHS is drowning in bureaucracy. This is not the way you can run things. I think also it's very interesting. Didn't Bernie Sanders take his honeymoon in the Soviet Union or some bizarre place like that? I think people like that are very much the young supporters of Bernie Sanders. Actually, they're not throwbacks to the 1970s collectivists. They're something else. There's just this kind of slight coincidence of view, but I don't think it's sustainable, because young people, they are much more kind of for themselves than people 4 or 5 decades ago, or what socialism demands of people. Even people on the left, I don't think will put up with it.
Well, I guess we'll end up seeing, and hopefully it never happens, because what we've heard today is truly shocking, terrifying, and really scary for what healthcare could look like on a much larger system here, and what it already does look like in the United Kingdom. That about brings us to the end of today's discussion, but where can our audience find out more about you?
That's a good question. I've written quite a lot, and the 2 articles I mentioned on healthcare, you can get off the Wall Street Journal website and just type in my name, and those articles should come up.
Well, thank you so much for coming on the show today to really share this important story that I think is not getting as much coverage as it needs in the United States and maybe even in Britain.
Actually, I think in Britain it's like something people don't really want to talk about. So it's really good to be able to talk about it with you and share it with your listeners.
And that's it for our interview with Rupert Darwall. I hope you enjoyed that. I found it very shocking and very appalling what has been happening in the United Kingdom with the National Health Service. Obviously, not in every single case where you have the system implemented, but it does foster and facilitate a culture, as Rupert put it, of death. So I hope you enjoyed this episode, and as a result, we'll go over to theedgeofideas.com/subscribe to get email notifications when new episodes are out. Maybe give us some feedback and criticism, praise, whatever you want at iTunes. Greatly appreciate reviews. They are very helpful. And again, thank you to our Patreons, to Zach for his tremendous $30 donation, to Mike and Julie and Tiana for their $15 donations, to Michelle and Scott for their $10 donation, and to everyone who's helped support the podcast so far. So a lot of interesting stuff coming up for you guys. I have done interviews already with Andrew Kessler, who is an expert on opioid policy in Washington, D.C. So that's going to be very interesting because opioid addiction is having a tremendous impact on the United States right now. I also have already talked with Clifford D. May, the founder and president of the Foundation for Defense of Democracies. We helped round out our conversation on Israel and Palestine and the conflict that has resulted there. It's an extension in our series, the first part being with Sarah Lee Whitson, the executive director of Human Rights Watch's Middle East and North Africa division. So a lot of very interesting stuff, but an interviews that you will only be able to listen to if you subscribe at theedgeofideas.com or on iTunes. So go do that. Go follow us on Twitter. I will see you next week for our episode. I'm Luke Scorzel, and you are listening to Bills.